Again, thank you, Bill. Dr. Janine Bera is the Chief Medical Officer for WellSpace Health, a nonprofit health center that provides comprehensive medical, dental, and behavioral health services to more than 100,000 people each year at 31 locations in Sacramento, Placer, and Amador County, I should say. And as a Chief Medical Officer, Dr. Bera leads a vast clinical practice serving the community's most vulnerable residents, including adults and children living in poverty, experiencing homelessness, or uninsured, I should say. Dr. Bera was recently recognized by Sacramento Magazine as one of the 100 notable business leaders of 2021. I look forward to her presentation. Please join me in welcoming Dr. Bera.
Good afternoon, everyone. I'm really happy to be here, so thank you for inviting me because I am very excited to share what we've been able to do as an FQHC in telehealth and all of the benefits that we have been given because of the emergency use authorization. So before I do that, I did want to share who we are as WellSpace Health, and our mission statement is achieving regional health through high-quality comprehensive care, and everything we do revolves around achieving this goal. We were founded in 1953. Our roots are in behavioral health and addiction treatment. We became a federally qualified health center in 2009, and in 2015 we were Joint Commission accredited. We now serve over 100,000 patients, and we have almost 1,000 employees. So we see ourselves as not a safety net, because a safety net is really that last ditch effort to get care, but we provide a blanket of care over 30 locations to provide access to primary care, well child visits, pediatric dental, maternal care. We deliver the largest numbers of babies born on Medi-Cal in the Sacramento region. We also do the majority of drug and alcohol treatment as well. So we are spread across 3 counties, and we have community health centers, immediate care centers, pediatric dental, behavioral health centers, and supportive services. And we go by a motto of everybody deserves to be seen, no matter who you are, where you come from, where you work, or what place you call home. And this is because we provide all of these services beyond just the basic primary care. We also have services that care for people who are experiencing homelessness, people who are experiencing violence in their communities. We also, of course, as I mentioned, do substance use disorder treatment. We partner with Birth and Beyond to be sure that our patients have access to the supportive services that they provide, and also many criminal justice programs. And this is just a partial list, so we do whatever is necessary to achieve regional health through high quality comprehensive care. So one of the programs I just wanted to really share is one I'm especially proud of, and it's the Ankh Sisterhood. That is a program that we started in response to working with the community in the First 5 Commission to reduce Black infant death. As many of you are aware, Black babies died at twice the rate of any other group, and through our program and through other programs in the community, we were able to reduce that to, it's always sad when babies die, but to the rate commiserate with other groups. So, and this program also now in the COVID pandemic heavily relied on telehealth to maintain these services. So when the COVID pandemic hit March 13th, Trump did declare a national emergency, and what this did for FQHCs is it changed telehealth from a system that did not allow equitable access to care, meaning anyone in an FQHC had to be within 4 walls. However, in employer-based insurance, telehealth has been going on for many years, and so people with employer-based insurance were able to get the care where they would like. They could be at home, at work, traveling, and still speak to their primary care provider, where someone in our system would have to be both in 4 walls with the provider and the patient. So on March 19th, in California, we were mandated to shelter in place, and many health centers, medical offices, dental offices and more closed, but WellSpace Health, we never closed. We recognize again our place in the community, and that is to serve the underserved and to keep them out of the emergency room so as not to decrease access to that most critical care, but to provide them a place to go before they get so sick. So we stratified our health centers into what we called COVID care centers, and those are our immediate cares. This is where we would screen. We were screening before pretty much right away so that we could triage patients to our immediate cares where they could be seen. And this also helped, as you might recall, it seems like a generation ago, but PPE, of course, was limited and we had difficulty getting it, across the world. And this also allowed us to conserve PPE by really focusing it on the areas and the health centers that needed it. And then our other health centers became well centers. This is where people who needed to come for their basic primary care could come and feel safe and get the care that they needed. We did not close all of our dental centers. We turned them into emergency dental centers so that if someone had a dental emergency, they could be seen for care. So with that call to emergency, equitable telehealth begins. And so this means that no longer do the patient nor the provider have to be within four walls. They could be safe sheltering at home while they got the care that they needed. We heard the directive and felt it wholeheartedly that a televisit should be the same as an office visit. So we focused our team-based care to maintain our PCMH, our patient-centered medical home. We're certified by Joint Commission so that we maintain that high quality of care. So what's on the right-hand side of the screen is just an example of the training that we gave to our care teams, to the provider, to the MA, to the front desk, that they still needed to do the screenings. They would ask for if someone had a blood pressure cuff at home, which why the self-monitoring devices will really help to move telehealth forward. And we did everything that we would do in a regular visit so that we had a robust visit for all of our patients and maintained our high standards of care. So in terms of workforce solutions, we also still are a business, and so we had to think about maintaining our bottom line. And when the CDA recommended the closure of dentistry, we did had to shutter much of our pediatric dental practices like I talked about, but we did stay open for emergencies and we did a furlough dentist. However, we had a win-win. We participate in the community-based care management entity, the CBCME, with our Health Homes program. And this is a program that reaches out to people who have multiple comorbidities to be sure that they get the care that they need. And many of these people have never had access to preventative care. And so we were able to deploy our dental assistants to train as case managers to support our CBCME program. And this way we were able to do even more outreach and utilize telehealth in order to be sure that the most vulnerable of the vulnerable populations got the care that they needed. So we telehealth visits over 2020 averaged about 10,000 per month across WellSpace Health. Now the majority of these were telephonic. This is the way our patients chose to access care. Excuse me. We did have options available for video visits. We partnered with some of the plans to have iPads donated to us so that not only could we provide translational services, we could access video visit capability, but still our patients wanted to use the telephone. So we respected that and were able to provide care. So here's some of our outcomes. So telehealth visits, I kind of like this chart because it's kind of colorful, but what you're seeing is the 4, 5, 6, those are the months of the year. So starting in April, you could see that the bulk of our visits were in primary care. In pediatric, we did have some dental visits. Now those must be video. And then even immediate care, and I'll talk about virtual immediate care. And here's some of our numbers. You can see the blue line here were our face-to-face visits, and the orange line was telehealth. So when that emergency order and shelter in place, you can see we had no televisits. We started doing televisits within 2 weeks. That means we got all of our providers and MA's front desk trained and ready to go. They were anxious. There was a lot of worry because, as you can see, we were having declining visits, and you can see how much it tapered off through April. And then with the increase of televisits, we neared reaching where we were prior to the shelter in order. So of course, this is important for access to care, but it's also important to maintain and keep our doors open at WellSpace Health. And here's behavioral health. I bring this up because it's been a special boon for behavioral health. And behavioral health, we did see an incomplete decrease in, again, blue line is the face-to-face visit, and the orange line is the telehealth visits, again, mostly telephonic. And as you can see, with the combination, we were able to even provide more care because now we're seeing even more patients who need to be seen for behavioral health or disorders. And we also started a virtual immediate care. This is where people would have same-day access. Now we have 4 immediate cares where people can just walk in at any time, and they have a focused visit on what their issues are. So we converted the same idea of our immediate care into a televisit. And so this also worked very well. And this is one where we have actually shifted more providers to doing this as we did still maintain what we were calling at that time our COVID care centers. We did a campaign out to our high-risk COVID patients who were at high risk for COVID-19 using our next-gen population health management tool that can stratify patients by risk. It looks at, do they have diabetes, CHF, HIV, cancer, those types of things, and then we could stratify it by race. It was apparent right away that our Black and Brown communities were not accessing care, and they do share the greater burden of disease, and they're afraid. And so through this, we were able to text message out to our patients using a Consejo Sano platform that are culturally sensitive text messages and appeal to people of different backgrounds. And at the same time we did that text messaging out, we also provided we had our care teams have lists of these patients to call out and let them know telehealth was available. They could get a televisit. They did not need to come in to WellSpace Health and still get the care they needed for their diabetes, their CHF, even their, maybe not obviously for cancer treatment, but to just be reassured and make a plan for how these visits were going to be held in the future. Because again, many of these specialty offices closed entirely. So in 1 month, we had a very successful campaign. We have done other campaigns like this in the past, and this campaign was very successful. We had over 31% of people who are African American actually make an appointment, and of those, 70% kept their appointment. And so this was an outreach that reached over 22% of people in this high-risk population. It was not as successful in the Latinx community, and we're looking into reasons for that, if it was a language barrier, if it was a lack of understanding about televisit, but we continue to do these text messaging campaigns out to the populations that are more risky and have them planned, of course, for COVID vaccinations to help overcome vaccine hesitancy and also to help make sure that we get, again, this population is being shut out and we want to do what we can to give them access to the vaccine. So back to telehealth. Here's how the no-show rate decreased. In-office visits, of course, our patients, like Bill mentioned, are most challenged by problems with transportation to get to an appointment. And again, with a televisit, they don't need to leave their home or can be wherever they're comfortable. So the televisit no-show rate was only 15% compared to 23% for an office visit. And we did a survey to see how do our patients feel about telehealth. Now it's 835 patients, so a decent amount. Of course, we did do a large volume of visits, and we'll be doing more of these to assess to see, is this still a way our patients want to receive their care? And you can see that over 89% strongly or agreed with the fact that it was easy to understand my provider and care team members. They felt prepared for their telehealth visit. And a large number, the greater percentage, also felt comfortable talking to their provider or care team over the phone, and that they would use telehealth in the future. So these results just again support this is the way our patients want to interface to get care. And again, these are mostly telephonic visits, and this is for English and Spanish responses. Another exciting thing that I'm very happy to report is that, and it's kind of amazing to me because we did have the, as you saw, decreased inpatient visits, increased telehealth visits and primary care, and still we were able to improve our diabetic control. We had fewer patients labeled as poor control during the pandemic, which is quite astounding. Anecdotally, when I talk to our providers, they say that what has happened was they were able to actually schedule more visits via televisits, and patients kept the visits more so that they were able to make the medication adjustments, order labs if needed. Again, labs did still, getting lab work done does still pose a problem, but this metric also looks at not only A1C of over 9, but also did a patient with diabetes get a lab test done. So it is both that are labeled as poor controlled. So our patients were still able, Quest is where most of our patients go to, and Quest did go to an appointment-based model, which our patients were still able to access and get the care they need to improve their diabetic care. So I'm very proud of that fact. Another thing that we noted was, as I said before, the other department that had the greatest benefit in telehealth was our integrative behavioral health program. We did over 10,000 visits, and 71% of those were telehealth. The no-show rate for telehealth visits was only 19%, while in-office was almost 40%. The pandemic was a stressful time for all of us, and many people were on the edge. And at WellSpace Health, we also run the suicide hotline for 53 of the 58 counties in California. And we saw over a 40% increase in suicide hotline calls. So with the ability to provide care became even more important, that people could be connected in so they could get the mental health services that they need that are provided with a telephonic telehealth visit. So in general, just to give you some information from before the pandemic, the suicide hotline basically provides telephonic support. You can think of it as a telephonic televisit, although of course this is not a billable visit, but it is still necessary to keep our patients and community, of course it's open to all, safe. In general, of those who attempt suicide and either call the hotline or present to the ER, about 43% go on to be fine. 31% unfortunately do commit suicide, and 26% have a repeat attempt at suicide. We have a suicide prevention program, and in this program, a suicide prevention specialist calls the patient daily for 30 days because we know it is within this 30-day period that a patient is most likely to attempt suicide again. And with this model, and we do coordinate with the ERs in our region, and we look to expand the service, we have never had anyone kill themselves, and we have only had 1% attempt suicide. I show this because this is the power of a telephonic visit. This is the power of being able for people to access care in the way they see fit, as opposed to what is delineated by policy. So we meet people where they are, and that is the basic tenet of being an FQHC. So the joy of equitable access, as you recall, I shared that prior to the pandemic, FQHC could only have both the provider and the patient within 4 walls, still providing a barrier to care. And I know many of us are talking about the importance of diversity, equity, and inclusion. Well, there's a difference, and many of us have seen that slide of the people on the fence where you have equal care and the people are of different heights. And when you give them equal care, they're still, if you're very short, can't see the baseball game. But if you have equitable care, meaning you give a taller box to the shortest person and a shorter box to the tallest person, everybody gets to watch the game. Well, that's just a game, but what we're talking about is access to medical care. We need to provide equitable access via telephonic telehealth, because this has been proven that this is the way our patients want to get care. And when they get care this way, we actually have improved health outcomes. In addition, I didn't talk about the improved provider satisfaction. It gives them greater control and flexibility in their day and allows them to feel better about the work that they do because they see these outcomes as well. So I showed you that also it overcomes the problem with no-show rates, the challenges with transportation, our improved clinical outcomes and diabetic care and suicide outcomes. And then we maintain our access to care. And of course, we all have to worry about our great bottom line. So we are able to meet our productivity goals through having this additional access for patients to contact care. So WellSpace Health, we say that we see you, and we try to, our main goal is to achieve regional health through high quality comprehensive care. So thank you very much.
Thank you, Dr. Bera. I appreciate it very much. So we're just a little bit ahead of schedule. I'm going to ask you to field one of the questions in the chat box. The question was from Casey Cameron. Have you been tracking quality outcomes for patients that receive physician services via telehealth? For example, has there been an increase, decrease in emergency room visits, or an increase/decrease in adverse health events subsequent to the telehealth visit?
That's a great question, basically, and those are the things that we're working on right now. That's the type of data that we are beginning to pull together. The first ones that we're looking at have to do with what happens in the exam room, like with the diabetic control. But as we move forward in 2021, then we can ask ourselves those questions and get the answers that we need. And I do believe that we will find an improvement, because I would think that initially we'll see an increase, but as that more people became acquainted and used to telehealth, we'll start to see a decrease again.